We welcome you to the instruction course on optical coherence tomography. The times have changed, and so has the gadgets with the ophthalmologists. I am Dr. Jha, SN Jha. I will be assisted by Professor Amit Khosla, Dr. Neeta Ganger, and Dr. Anil Solanki. We are all from Gangaram Hospital, New Delhi. Dr. Anita Sharma could not make it due to some personal pressing reasons. So as I was talking that we have moved from the loop and torch to the slit lamp, and now hardly any ophthalmic setup is complete without optical coherence tomography. But at the same time, sometimes we get too much carried away by the OCT and think that OCT can tell us everything. But OCT is a part of the armamentarium that now ophthalmists have and should be seen in that light, and not that totally only rely on the OCT findings. Always correlate with your clinical findings, which is the most important still. Other imaging, the patient's profile, everything comes into picture. So OCT should be taken in toto when you interpret the OCT findings. So first I will be touching on the basics of the OCT. We'll give you an overall view what OCT is all about. And then we'll have Dr. Anil Solanki will talk on the interface. And then Dr. Amit Khosa will tell you the most recent advance in OCT, Octa, which has a great future. And this possibly, I'm not very sure, but possibly will wipe out the fundus fluorescein angiography, which has been our friend for last more than half a century, and which has been very useful, but will be a sad day when we have to say goodbye. But it's at the same time will give a lot of mental relaxation to ophthalmologists, because ophthalmologists still hesitate in doing angiography because of being an invasive in nature. So we'll move from totally in retina from the invasive to non-invasive area. It will be followed by Dr. Anita Ganger's talk on neuro-ophthalmology, where we do help our colleagues, neurologists. It's a big thing which has happened to us, that we are very objective when we tell our neurologist friend, look, this your papilledema is not going down. The benign internal hypertension, that we help them, assist them, and treat them and monitor the patients, because the only problem with benign internal hypertension is blindness. Patient survives, and we don't want to survive a blind patient. So here the ophthalmologist come a big way and big help to the neurologist to guide them to continue treatment. Sometimes patient is without headache and all that, but still might need treatment so that the blindness doesn't come on patients. Last but not least, of course, we will be impinging on our glaucoma colleagues area, but at the same time, I think it is our duty to all the patients after 40 years that even with the slightest doubt, we should rule out glaucoma. And ganglion cell analysis has come in a big way. It's a warning sign that we are all aware now, and we do take notice of that and make patient aware of that. Though it may not entail the starting of treatment, but at the same time, it makes us aware of the problem that we might face in coming years. So thank you very much for coming and attending. We'll have a good interactive session, I believe. So I will start my basic presentation. So we'll just a brief history about 1900. Albert Abraham Michelson invented interferometer. It's a basic principle that we all now know, that it's based on the principle of interferometry. Then the first in vivo imaging was in 1990s. You'll be surprised to know that the OCT was first used in cardiology, not in ophthalmology. But as we are optically accessible, most of the new gadgets in science helps us by coming into our domain. First commercial time domain OCT was introduced in 1996. The young ophthalmologists will not be aware it was such a big leap for us. I cannot tell you the feeling that we got once we got this machine and started diagnosing, which we are not able to do. We started treating the patients when possibly we thought doesn't need treatment. And of course, the big change again came with the spectral domain OCT, when things became much easier to interpret, much faster, much comfortable for the patient. I'll just give you a basic guideline how to interpret your OCT findings. You should visualize retina like a building coming up. You have beams, you have pillars. So your all horizontal structures are like beams, and the columns are your Muller cells. As we all know that they guide the pathologies in the retina to appear differently. a flame-shaped hemorrhage in the neural retina, whereas a deeper retina will give a dot and blot hemorrhages. So OCT at the same time you must interpret when you are interpreting OCT, because the retinal structure is like a building coming up. This is just to giving you a brief history what imaging that we have and what is the resolution. The confocal is of course the most say resolving gadget we have, 1 micron. The ultra high resolution OCT again is coming, which is possibly right now in more of investigative domain than in clinical practice. The more we had around 10 microns of OCT coming. Octa of course has totally changed the this whole spectrum. Ultrasound we are all aware, and high resolution OCT 300 micron and MRI 1 millimeter. Here I will just like to give a basic idea about the young ophthalmologists that you should see OCT like an ultrasound. Where in ultrasound you use sound waves, here we use light waves. So the problem with the light waves will be that it might have obstruction, may not get that good vision in a media which is not that good. But at the same time, because of the low wavelength, the light always give you a better resolution than ultrasound. So it's like an ultrasound with the light. So that way, the reflectivity, the absorption, the shadowing, everything you can superimpose and you will get a good idea how the OCT will work and look like. So this is just giving a normal that we are all aware. You have pointer? Okay, so as we already talked about the low coherence interferometry, that there are two mirrors, that one reflects and other catches, and in between this is basically an area of physics that we cannot go into deep into that, and what we are basically concerned with the type of image that you get. And remember that these images are basically made by the computers, their software, so it can vary from patient machine to machine. See, this is a spectral domain OCT, and this is a time domain. Here literally the pilot has to look out to land. So we need a lot of time. The patient also have to be on longer time on the machine to interpret a lot of data and that to see in that time. Well, the spectral domain, because of its simultaneous high, resolving capacity, it gives you a much faster, much clearer picture, and normally doesn't miss out. Whereas in time domain, sometimes we used to miss out some of the macular lesions. A spectral domain doesn't give us that scope to miss out because it takes the whole picture in one go. So this is a big change that we all came to have. This is a detailed of all the machine that we have. This was the first one. I think we are all very thankful to this machine to give us a real insight in retinal disease. Of course, then the improvement is taking place, and day by day we are getting better machines. So these are all machines that we are having. We are all aware of that. This is a normal OCT that you will have. So just one thing that I like to highlight here, you are seeing a black and white picture. Actually, this is the ideal OCT that we should give to the patient, but normally we give pseudo colors. Pseudo colors sometimes miss out some of the lesions which are not that clear. And one thing we like to just have, these are the other thing that you will come across is all right, but see, this is a line. This is nowadays we look for this line in a poor vision. We are not to find out why. So always look for this ISOS junction, or sometimes say it is an ellipsoid area that comes. This, if you see this area, it is leaving for a while. It appears to be leaving the RP for a while at the fovea. It's because the cones are very thick here, so there is a vacuum in between. It's not that the cones are not attached to the RP at this stage, but there is a gap because the light wave will only catch when there is obstruction. So this is a vacuum area, so it's just lifting up because of the high cone heights in this area. So what is OCT in ophthalmology? We all know, very important for diagnosis, even deciding treatment, and of course follow-up. So all three areas of our managing patients is covered by the OCT. And of course, as already we have discussed, neuro-ophthalmology. We will be leaving out the entire segment here. So common cause of abnormal repeated optical coherence tomography is the hyperreflective. So whenever the light will find an obstruction, it will come back, and that is what the machine catches. So the heart exudates, calcification, they will reflect the light waves, blood, scar, and epiretinal membrane. We are all aware that how reflective the ERM becomes on OCT. And of course, hypoinfective, when there is a fluid, there is retinal edema, when the light is able to go through, because we will not get any signal from there. Same as ultrasound that we see. And of course, this is again, I will come later, this is very important part, loss of tissue. We do make mistakes when interpret this finding in OCT. So this is all the type of, that you have a software available that you go through the patient's eye and get the different data. Coming to the area that we look for, normally vitreous is very clear, and of course, in certain situations, you will get echoes, not very important from our point of view, that much, more of, say, teaching the students. Vitreal interface is one of the most important thing, particularly in diabetics, that you have to look for. Foveal contour is another area, and intraretinal, of course, and subretinal fluid will have different implications. And we all know about that in diabetes, such an important thing to look for all this. So vitreous normally is clear, so you can have floaters in vitreous. Astrodialysis gives a very interesting picture on OCT. So they see like falling raindrops you will get. And there is a large vitreous floater which is producing a shadowing effect. Preretinal abnormalities are again very important, that we always have to look for and see whether there is any traction or any thickening of the ERM. So this particularly becomes very important in diabetic patients. Sometimes you might feel that you are not able to see that clearly in edema in diabetic, but vision is poor. When you do an OCT, you find very clear-cut VMT, and this of course a clear-cut indication for surgical intervention. We all aware, and you must have seen all these pictures over and over again, but it's very important from the patient's and the surgeon's point of view, that you clinically you see, okay, it looks all right, doesn't look that bad in macula, do OCT and you find this picture and gives you the whole idea of the poor vision. Epiretinal membrane, again, it's a surface on the retina, hyaloid and all that, makes thicken with the age. Again, this has to be taken with a pinch of salt. Don't run for surgery in any ERM that you see. Always correlate with the vision, the patients having symptoms or not that. So it can be focally adherent and globally adherent. Normally here you should not rush for surgery unless you are really documenting the vision is falling down. Focally adherent, of course, and if it is affecting the foveal area, of course, you have to intervene. So this is, see, there is a change in the retinal texture, but again you have to correlate with the vision. Sometimes OCT like MRI shows more than actually what is needed to be done. These are the, I am just making the routine lineup for the diseases. Important areas will be this retinal edema. Again here this has come a handy for us. You operate a good cataract, you have no problem, but the patient suddenly complains after 2 weeks or 10 days that vision has gone down. You are worried and you do an OCT and you find edema, then you can reassure the patient. Most of these patients will improve on their own. You have to just wait. Subretinal fluid, again, you have to pick up in many situations, and it has one indication that these patients are going to recover better vision than intraretinal fluid. Macular hole, of course, it is a guiding principle nowadays. Again, this lamellar hole or pseudo hole. Sometimes on clinically it appears like a full thickness hole, but when you do an OCT, you find them, then you have to again reassure the patient. And juxtafoveal telangiectasia, I will come to this. So this is, of course, this is one, I will just find a clinical important thing I would like to mention about the BRVO, that if you see half of the retina thickened, you are only seeing an OCT picture, then you can get that this could be a BRVO. And this is of course the diabetic edema again, but here again you see this. But normally if you say only half of it going up, the most possibly of a BRVO is very high. And CRVO, of course, is a edema is very high, very thick. Macular hole, of course, we are not going detail. Is a diagnosis and staging, associated ERM, surrounding retina, cystoid and prognosis. We have the whole foreign factor and all those things will go a long way in deciding the surgery and about the prognosis that you will expect to the patient. So again, this is a very common picture that you are all aware. So this is again an important thing when you go for a whole analysis. If there is a tissue left, even if a minor tissue left, these patients possibly will not need surgery immediately. You can just follow up. This I would like to highlight because we all have made mistakes. When you see these patients in the beginning, the injection injectors, you sometimes get carried away that could be an edema. But if you see the foveal contour is well maintained and there is evacuation, this is a loss of tissue. These patients are not going to improve any type of intervention. So just explain to the patient what is this situation like. Again, here I will not go in detail because we will be coming other talks. This neurosensitive attachment is a very, very important thing to look for in all your patients where there is some doubt about the why vision is not improving. Drusen, more of a clinical, academic importance, and really you don't actually make much out of it in OCT as such. And of course, we are not going into detail about this. We all have a lot of discussion on this ARMD, universal AMD, and the treatment is straightforward. But again, one thing that you have to always be very clear about, sometimes OCT will show a lot of changes and maybe some fluid and all that, but you must look for clinically the risky form you start. These patients are not going to do well with your injections. So don't rush through in these patients for interval injections. And this is again a dry type of macular degeneration. And these are some of the pictures, the pre and post treatment. Again, we have seen a lot of that. Again, one thing I like to mention here is CNV with myopic degenerations. If there is a distortion in the high myopic patients and there is a compromised vision, you may not find much fluid in these patients, but you should inject. These patients do quite well. They require much less in number of injections than other AMD patients. So don't wait for the fluid to come in myopic CNVM. And again, sometimes you have all made mistakes. The viral form dystrophy and we have injected. See, there is no fluid around. There is no fluid around. And this is a thing which is now we are diagnosing more and more with the new gadgets that come, polyfocal vasculopathy. And of course, the one thing I just like to mention here, when you make a diagnosis of CSR, which is very commonly seen, just try to look, there is no intraretinal edema. If there is some fluid here, you should revise your diagnosis about CSR. So the important point is that in AMD, you achieve a full dryness, try to achieve. In diabetic, you should not go for that straight away. You can see the vision has stabilized, is not improving the injections, wait and just watch for the vision to drop, then you re-inject patients. When you have unexplained visual loss, you all come across unsatisfied patients, we don't know what has gone wrong. This is very important. Look for foveal atrophy. The thickness of fovea will go down, disruption of IS organization, and subtle serous detachment. The third one will definitely recover, but these two will never recover. So explain to the patient, try to tell them that this is what we can do maximum, can't do much about these patients. So thank you very much for your kind attention. I think I now invite Dr. on this forum.
Good morning all. Thank you sir. Thank you AIOS for giving me this opportunity. I will be talking about role of OCT in vitreoretinal interface disorders. So I will be talking about anatomy, brief about anatomy and various disorders in vitreoretinal interface. So anatomy vitreous makes up to 80% of the total eye volume, and it is composed of 90% water and 2% protein, which mainly contain collagen and other constituents like hyaluronate, chondroitin sulfate, fibrin, and opticin. The vitreous is strongly attached at certain points, which you should always know. That is the optic nerve head, macula, ora serrata, and around large blood vessels. And the interaction of posterior vitreous cortex and hilum is what make the vitreoretinal interface. So this is the vitreoretinal interface. You can see this is the posterior cortical vitreous. It is attached at the hilum, and problem with this lead to the different vitreoretinal interface disorders. So what is normal procedure? Normally at the age of 4, synchisis and synthesis started. What is synchisis? It is liquefaction of vitreous which creates the lacunae and pockets in the vitreous. And Along with this, there is vitreous condensation. This process started at the age of 4 and keeps on going with age. And finally, the whole of the vitreous gets separated from the retina and leads to the complete PVD when there is clean separation. But this is the example of vitreous liquefaction, which you can see here also. This is sometimes called premacular bursa, the clear space. And this is complete PVD. You can see it on the clinically, you can see it as a Weiss ring, and on OCT you can clearly see the vitreous is separated from the optics as well as the macular area. So in disease state, what happens? There is loss of harmony between the liquid vitreous cortex liquefaction and its detachment. If the liquefaction process happens faster than detachment, then also lead to the disease problem, or there is abnormal adhesion of the vitreous cortex to the ILM. So there is namely 4 disorders. First one is vitreomacular adhesion, vitreomacular traction, macular roll, and epiretinal membrane. So vitreomacular adhesion is basically incomplete separation of posterior vitreous with persistent attachment to the macula. And as such, patient doesn't complain of any symptoms. It is known as early stage of PVD. So this is the picture of VMA. You can see it is getting started from the perifoveal area and still attached with the fovea, but there is no distortion of the foveal contour. So on clinical examination, slit lamp biomicroscopy, you will not find anything. According to the International Vitreomacular Traction Society, they have divided it into 2 classes. One is focal and one is broad. Focal is when it is less than 1 disc diameter in size, that is less than 1500 micron, and it is more than 1500 micron, it is called broad. So this is example of focal. It is attached the fovea without distorting it, and this is broad. So it is asymptomatic and non-pathological and considered as an incomplete PVD. So treatment, though no treatment is required, but we have to observe because it is hypothesized that it plays role in pathogenesis of neovascular AMD, macular hole, and diabetic macular edema. So on observation, it may lead to the complete resolution, or it can progress to the vitreomacular traction or macular hole formation. Vitreomacular traction. On slit lamp examination, the signs are very subtle. You may see a distorted or blunted foveal reflex, and if it is traction is high, then you may see cystic changes or subretinal fluid. But on OCT, you can clearly identify it. You can see there the fovea is distorted, cystic spaces are seen inside the intraretinal cystic spaces are there. What are the symptoms? Patient may came to you with the complaint of blurring of vision, but the most important feature is metamorphosia or micropsia. So, like VMA, it is also classified as focal and broad. It may spontaneously resolve in 1/3 of the patients. So when will you intervene in case of VMT? For blurring of vision, we will not intervene, but for metamorphosia, which is significant, we can intervene even with the good vision. So when there is persistent blurring, significant, or there is metamorphosia. So the surgery is pars plana vitrectomy. What are the outcomes? Visual acuity improvement is seen in 44 to 78% of cases. 1/3 of them will gain more than 2 lines. Visual acuity may not improve, but there is definite improvement in the metamorphosia. And complications are as related with the pars plana vitrectomy. There was one agent which was approved by FDA in 2012, ocriplasmin, which came with a bang, but it was very expensive and overall success rate was very low, that is around 27%. And post trials, certain complication was also reported, like loss of ellipsoid zone and decreased amplitudes in ERG. So, and it is also not useful in very severe cases. So nowadays ocriplasmin is no longer used. Then the third entity is full thickness macular hole. Its incidence is 0.05%, female predominance. It is basically full thickness defect in all the layers of the retina, and the pathogenesis is anteroposterior traction of vitreous and the tangential contract of perifoveal vitreous cortex. So these are different stages which were given by the gas, and we can see them on the OCT. Like this is completely normal. Then there is traction VMT with, so this is, the VMT is basically stage 1A of gas classification, and if there is lifting of it from the RP, then it will come stage 1B. When it become complete, then come to the stage 2. Then when it increases in size, become 3, and with complete PVD, it becomes stage 4. Recently, apart from the different indices which are given for the OCT, the main is IVTS classification, which classified on the basis of size, in which we will measure the least, the minimum distance. We have to take the minimum distance, and if it is small than 250 microns, we call it small. 250 to 400, we call it medium, and if it is more than 400, we call it large macular hole. For prognosis, 50% at the stage 1 either will go into resolution, or 50 they will move to the stage 2 or 3. For stage 1, we can observe because there is 50% of chance. For stage 2, it will definitely progress to 3 or 4 in 75% of the cases. And prognosis of untreated full thickness macular hole is 5% will have good vision, but as you see, the maximum patient will have poor vision. So we usually intervene after stage 1. So management is with vitrectomy. For stage 1, we can get away even without ILM peeling, but for stage 2, ILM peeling is definitely we have to do, along with the SF6 or C3F8 tamponading. Along with that, for more than 400, ILM peeling with inverted flap is required. And some says that combining with phaco surgery, the outcomes will increase. Face down position classically is for 2 weeks, but nowadays 1 week is sufficient. We see even for 4 or 5 days sufficient for macular hole surgery. So this is lamellar hole, which sir was also telling. In this, the central photoreceptors are intact. So these patients usually have very good vision, and they doesn't require any surgery. It happens because of the anomalous PVD, and it is said to be abortive full thickness macular hole formation. The last is epiretinal membrane. It is basically cellular proliferation that creates a semi-translucent fibrocellular proliferation over the surface of retina. It happens because during the PVD there are breaks in the ileum, and through those breaks glial cell migrates and they form this membrane. Symptoms are blurring of vision, metamorphosia, micropsia, and even monocular diplopia can be there. Clinically, we can see a reflective membrane over the retina, and wrinkling of retinal surface can be seen. So this is the OCT picture showing the ERM. Of Japanese group tried to look at the visual correlation with the ERM, different ERM. So they divided the ERM into 2 groups: fovea attached type ERM and pseudo-hole type ERM, in which the fovea is not involved. And the vision was good in fovea sparing ERM, but for fovea involving it, they divided into 3 groups: 1A, 1B, 1C. In 1A, there was thickening in outer layers only. For the 1B, there is thickening of outer as well as inner, and there is protrusion of outer layers inside the inner layers. And third one was the thickening of, diffuse thickening of the inner layer. The visual prognosis was poor from 1A to 1C, and they confirmed it on the ERG also, multifocal ERG. For management, usually we hold our hand because most of them, it is around 85 to 90% remain stable over 2 to 4 years. Only 15% will deteriorate with time. And the surgical indication is if the vision is less than 6/18, or there is significant metamorphosia or diplopia. So pars plana vitrectomy with membrane peeling by using of trypan blue or brilliant blue. And we peel along with the ILM because that ensure the whole of the ERM is removed. So at conclusion, I would like to say that there are different studies from the south and from the west which shows that even after the examination by the competent retinal surgeon, 20% of the patients were missed on clinical examination, which are captured on OCT, and they were patients of ERM and vitreomacular traction. If your patient is complaining of distortion, metamorphosia, and you are not able to see anything on slit temp examination or 90 examination, you should go ahead with the OCT because it can be missed. Thank you.
Now I invite Dr. Amit Khosla.
How many of you are anterior segment or posterior segment people? How many of you use OCT on a regular basis? So what I would recommend is when you see a OCT, just give you some tips that you see 4 things. You see the normal contour. So even if you don't know how to read OCT, just think of 4 things. What is the normal contour? Is the too dipped, it's thin, or it's elevated is the ERM. Number 2 is what is the vitreometal interface? Can you see a membrane or not? Number 3 is the thickness. You may have a normal edema, you may have a normal contour, but you may have the thickening or a thinning. Number 4 is the IS-OS junction, this which Dr. Jha showed, small one. If that is injured, then you have a damage to the retina. It's not good. So all unexplained visual losses, what we recommend, fields and an OCT to pick up any vision loss. Number 2, you have any patient of cataract and you feel that the cataract is not commensurate with the vision loss, get a OCT done, that is an indication. Number 3, that all of you are doing premium lenses. So in a premium lens, whether it's even a toric, get a OCT done before, because you may have some membrane and the patient will not respond. So that one of the unhappy patients after cataract surgery is a patient whose OCT hasn't been done. So, right, so normally you end up doing an OCT after the surgery, get it done before the surgery if you're doing premium or patient expectancy are higher. And especially in diabetics, sometimes you may have a small vacuole or CME which will not picked up clinically, you may have no microaneurysms. So those patients who have suspected macular diabetes, hypertension, who had BRB or CRBs, remember that you don't need to go into the layers, just see the thickness, the contour, the interface and the IS-OS junction, you'll be fine. So the topic I'm speaking is, it's more limited to the retinal surgeon, but it'll give you a future where we are going. So 1998, I think the OCT was started. It took about 12 years for them to analyze the vessels of the retina. So basically on the fluorescent angiography, you get a foveal avascular zone. On the OCT, the en-face, you can have an idea. But the retina has the superficial retinal vessel and you have a deep capillary plexus and superficial capillary plexus. So you get the motion artifact. So whatever is moving, you will be able to find out. If it's not moving, you will find it as a blocked artery, right? So will FA be replaced? It is being replaced, but finally will it be, because the leakage is not picked up by the OCT angio. It will not show pooling. So sometimes in a diabetic, you may have no CME, nothing, but we do FA, there is a mild leakage, means the retinopathy has started, but the OCT angio will not show any dye and uveitis will not show any changes thereafter. So the dye-based angiography is low resolution and the OCT takes less time, the less flash, and can be done multiple. Repeatability, non-invasive, that is where the Octa is scoring higher. So if I have to show that normally we have 3 layers. So there is a superficial, deep and the intermediate, but majority of them of the OCT angio just show the superficial and the deep layers. So what we have learned from Octa is that each layer infarct can cause some other problem. So if you have an artery, you have arterial occlusion, venous, but if there's a capillary occlusion, superficial nerve fiber will be a soft exudate. So you can have PAM, you can have, so there are 3-4 terminologies come for infarct of each layer. So you see a whitish patch and the OCT angio will tell you which layer it's getting affected. I'll show you the details. So basically the superficial capillary plexus and the deep capillary plexus, which has an intermediate capillary plexus. So different OCTs show a different flow sign. So this is the superficial and the deep vascular plexus. If I were to do a OCT angio on different machines, there's a different segmentation, different, the resolution is different. So you will see a different pattern on each, but it shows up the foveal avascular zone. This is the chorea capillaries. You can go to the level of the chorial capillaries. So there are various machines which use different sources of software. With some are HD, one are swept source, and the resolution is different, and they are increasing the resolution. The only issue is that all our OCTs, I have superficial ones. Only the swept source can go deep, or you have an EDI where you press and you segment the layers separately. So as I mentioned, different segmentation layers and different scans. So any stationary object will not be streamed. It is just that the motion artifacts which you see, the movement you see. So these are the various machines and how you can see the various layers of the, so the superficial, deep and the choriocapillaries. So does it have a role over what is missed in a OCT, which you need a OCT angioform? Basically, choroidal neovascular membrane. So we are taught that a choroidal neovascular membrane leaks, and when it leaks, it causes edema, you treat. So if I have a choroidal neovascular membrane which is not leaking, so do I need to treat? Yes, if there's metamorphopsia, but if there's a subretinal membrane which is not leaking, which is not causing metamorphopsia, you may not treat. That is a doubtful indication. But yes, if you have metamorphopsia, some CNVMs don't leak, like the myopic. So you may have no fluid, just the distortion. Difficult to differentiate in a PED with CSR. So as I mentioned, in a CNVM when going from dry to wet, and does the presence of a CNVM on Octa help me retreat? No, it's a controversy. If it's dry, you may not treat. It's not going to disappear. This is a very good indication. We had to do a ICG to pick up a CNVM in a patient with CSR. In uveitis, sometimes you have a CNVM in a serpiginous like where you miss out and think it's just a recurrence of the edema. Diabetic retinopathy, we all are worried because of the angiography. The angiography gives us a better clue. But yes, this is picking up the NVDs, NVs and the macular ischemia. So it's non-invasive, repetitive. You can't do a FA repeatedly, but it is helping us. In BRVO, it is giving us a sense of the ischemia. But if you go to the BRVO and CRVO study, it said so many disc diameters of ischemia. Since the OCT only gives us the posterior pole 12 by 12, we do not see the peripheral ischemia, which is only visible on a fluorescent angiography. Now in the MACTEL, Dr. Jha showed the atrophy telangiectasia, which you want to pick up a CNVM. So here is a type 1 CNVM, which is visible. You can see the net form, which comes in the, so basically you're looking for a CNVM. This is type 2 CNVM, it looks different. You can compare with the FA, and these are the polyps which can come up. You see the polyps on this. So basically, OCT angio is basically for the CNVMs, not for anything else in the retina. So what is the disadvantage? There's no leakage, no pooling. But sometimes if there's no pooling, you can pick up the CNVM. Sometimes the early and the late leakage blurs the CNVM on angiography. So you need to have a OCT angio when in doubt. So suspicious CNVM complicating CSR helps you pick up. So here you can see but the only problem is that the machine segmentation is the problem. See, when you're doing a normal OCT, you have a straight line. But when there's an elevation, the machine itself does not segment this layer. It will just take a line here. So you have to manually then reset. So it can't be done by a technician. OCT has to be done by you because you will have to create this layer. The segmentation is going to be poor. Sometimes a simple NV looks like a CNVM because the retina is elevated. So as I mentioned that I have seen a CNVM, but there's no fluid, there's no metamorphopsia. Doesn't mean that every OCT, CNVM has to be treated, because if it's not leaking and it's dry, you may just wait. Injection is not to make the CNVM disappear, it's just to keep the retina dry. So what happens in a diabetic? You see the elevation coming up. So between an IRMA, which is a ischemic, but is it a new vessel on leakage? The elevation in the vessel over the retina will tell you a new vessel is being formed. So on trial basis, they have made huge machines which can tap the whole retina end to end for a angiography for trials. It's not commercially available, but they're even doing just a OCT of the whole retina in ROP screening, because they can see the vessels coming up. So tomorrow, as it becomes reproducible, you will have OCTs which can map the whole posterior pole up to the ora. But they are too bulky research tools. So you're going to have them picking up the NVs and the NVDs, which you may not want to do an angiography. So here you can see a patient with an NVD, and you can see the elevations of the NVDs coming up. So you have to learn, and it's difficult doing it and interpreting the OCT angio. It's a learning phase. Maybe in the next 2-3 years we have. Here the NV is there. You can see the NV. So what people are now using is trying to map the posterior pole for diabetic retinopathies, looking for the ischemia. The micronism will not look. They look like saccular pouching on this. So can I pick up early early diabetic on OCT, you may. But remember, if you are doing fundus photography, I'll advise all of you to buy a fundus camera, whether you're interior or posterior segment surgeon. They are coming and you do regular photographs on diabetic. If you do a red free, you will pick up the microvision better. So a red free photograph gives you a huge finding. And if you can buy a contact lens and use on a slit lamp and you can do a wide angle 3 mirror, you will pick up a lot of lesions. So if you want to correlate your OCT, learn to do a 3 mirror or a wide angle mainstay lens so you can see the whole retina. You can see the NV there. So MACTEL, you can see the abnormal vessels, but you don't see the CNVM. In a BR view, I told you, you can see the ischemic areas, how much the ischemia is, and it's easier to explain to the patient. So sometimes, as I mentioned, the segmentation is going to go straight. If there's a bump, you will have an abnormal, so you'll have to reset it here. So this is the normal segmentation. Manually, you have to resegment it to get the right layer on a OCT angio. So what are the disadvantages? One is motion artifact, because it takes time more than an OCT. The movement creates a motion artifact. You see these lines, right? So they are the biggest problem in trying to understand a OCT angio. And the tracking, if the patient is moving, the tracking. So the SLO systems track better. They have better penetration through this thing. And if you have a blood, again, you cannot see the CNVM properly. So the limitations I mentioned was that some start with 3x3, some 6x6. Now up to 12, we have the mosaic. So they superimpose 4 or 5 photograph and create a mosaic. So you see it like a fluorescent angiography. So in summary, it is a diagnostic tool still basically for CNVM, but we don't know what is the best answer to treating. So I'll just show you a few cases. This is a CNVM now that you have seen multiple ones. It looks nice, but sometimes you have a very dilemma, is it or is it not a CNVM? Here you can see the lesion, the infiltration, and you may have a RP rip. This is a CNVM without a fluid. So this is called a SHREM, subretinal hyperreflective material. So in a choroiditis on a person, when you see a SHREM, subretinal hyperreflective material, you do a OCT angio or a fluorescent angio to look for CNVM. So SHREM, only 15% will be CNVMs. So myopic, as I mentioned, you may have metamorphopsia, you may not have fluid. So normally a normal OCT will not help you monitor a myopic CNVM. Either you have to do a fluorescent angiography to see where it's there, or a OCTA. A simple OCT sometimes does not help you pick up a CNVM in myopic. So as we mentioned, sometimes you have chronic CSRs where you have PEDs and then you cannot pick up. So the OCT angio will help you pick up the neovascularization. So I'm just showing you a few examples. We've already discussed the fluids. CNVM in fluid, you can see sometimes the resolution of the CNVM also on the OCTA. So basically, as I mentioned, CNVM is the most important parameter, but if you have a good OCT and resolution, you can pick up the fluid. You do not, once you've diagnosed one, follow up, you do not require OCTA. OCTA is only required when you have a doubt of a CNVM to diagnose a one, and that also when there is fluid. Thank you so much.
Thank you, Dr. Amit, for highlighting the features of OCTA. Now I invite Dr. Anita Ganger to talk about the OCT in neuro-ophthalmology.
If you have any question about retina, because we finished in the retina part, any questions you can ask.
Any questions to ask from the retina specialty?
I think we have explained very well.
Yes. Very good morning to everyone. Firstly, I would like to thank AIOS for giving us this opportunity. After such an elaborative talks on retinal disorders, I would be moving towards the application of OCT in a neuro-ophthalmological conditions. So I have no financial interest to disclose. So now I will not discuss OCT as a machine because we have already discussed it very nicely. So this is the evolution of OCT, which is a non-invasive and non-contact technology. Just a brief review what the printout looks like. So this is the OCT printout, where in this section we see the patient details, This tells us about the what has been done in a particular patient, whether we have examined the macular area or the optic disc cube, along with the pixel strength and the laterality of the eye. This section, this is showing the RNFL thickness maps, and these are the various parameters we assess while doing the OCT RNFL. And this is the gray picture of a OCT fundus image. And these are the graphs showing the as comparison to the general population, how in a particular patient these are deviated. And these are the quadrant wise thickness, and this is the average, this is the 8 clock hours distribution of the RNFL layer thickness in a particular patient. So this is just the brief what we see in the OCT printout. So now my point of discussions would be the imaging parameters. What are the useful parameters we see in the neuro-ophthalmological conditions, a disease-specific OCT findings, and then the important points to consider. So now coming to the role. So how it helps us in a neuro-ophthalmological condition. Actually, OCT is a surrogate marker of neuroaxonal integrity in an afferent visual pathway. It helps us in diagnosing various conditions, disease monitoring, and to prognosticate. That is also another useful application where we can prognosticate the patient as per the OCT findings. So then the most valuable structure parameters are RNFL thickness and the GCL thickness. So now the disease entity, optic neuritis, what we mostly see in a neuro-ophthalmological condition. So OCT can be used as a quantitative tool to monitor the course and the treatment. So initial spike in RNFL thickness is due to the exoplasmic flow stasis, which can mask the earlier signs of axonal degeneration. Initially, we will see the increased RNFL thickness, and there we don't know whether it is the axonal degeneration already happening or it's just edema at that point of time. So macular OCT scan is another important adjunct in such situations. So like case 1, this is a MS patient with optic neuritis in the left eye, showing initial spike of RNFL thickness. So initial spike of RNFL thickness, which is masking the axonal degeneration. So here we can see the OCT picture of same patient showing marked GCL thinning. So that means axonal degeneration has happened in this patient, which GCL has shown. So now coming, I'm discussing this important paper where retinal nerve fiber layer thickness and visual functions have been assessed in a patients of optic neuritis and multiple sclerosis. And this study has concluded that RNFL thickness is reduced in optic neuritis patient and even in the multiple sclerosis patient where the optic neuritis attack has not yet happened. Then also you can see the deranged parameters. And then, and the pattern was similar to the Caucasian eyes. So now coming to the another important publication, I was the part of this publication where we have assessed the RNFL layer and GCL changes on OCT in a multiple sclerosis patient, early multiple sclerosis patient. And we have seen that GCL thickness is a more sensitive clinical parameter than the RNFL, especially in an early multiple sclerosis patient. And ONS patient and the GCL correlates better with the visual parameters as well, better than the RNFL. So now coming to the NMO spectrum diseases. So what different we see in a NMO spectrum disorders as compared to the MS, multiple sclerosis. Normally in a NMO spectrum disorder, RNFL is affected in all the quadrants as compared to the MS where mostly the temporal quadrant is involved first. And many a times in NMO spectrum disorder, if the optic neuritis has not yet happened, then you can find the normal RNFL values. Whereas in multiple sclerosis, even without the optic neuritis attack, you can see the deranged values. And then the mean RNFL loss in multiple sclerosis, it's around 20 to 30 micrometer, but whereas in NMO disorders, it is much more profound. So around 55 to 83 microns. And in the NMO spectrum disorder, there is a higher prevalence of microcytic macular edema. So now coming to the ischemic optic neuropathies, OCT can be used to identify the treatment effects. The thickness of macula, OCT and GCL is expected to provide a better structural indicator. And even in ischemic optic neuropathies, the distinctive altitudinal pattern of the GCL loss can correspond to the altitudinal field effect as well. So you can correlate on OCT as well as the field perimetry. So here the left NAION, in acute stage the optic nerve swelling caused the RNFL thickening which has masked the axonal loss. However, GC-IPL analysis showed abnormal thinning. So then another case, which was an old case, left eye NAION 3 years back, showing thinning of the superior-temporal aspect in peripapillary RNFL. So here in a chronic case or in a recovered case, you still see the thinning of RNFL. So there is a floor effect also with OCT which limits the detection of progressive RNFL GCL above 30 to 50 microns. So if it is a very advanced disease, it should not be interpreted in isolation. Like this is this much thickness has gone. So you have to correlate clinically as well. And along with the multiple sclerosis, role of OCT is getting established in other diseases like Parkinsonism, Alzheimer's, etc. So now coming to papilledema, definitely a very good application of OCT here. So change in the optic disc edema over the time can be better quantified. So many a times we have to objectively see these are the values, these are getting lowered or not. So sometime to the neurophysiologist, neurology person also, neurology specialist, you have to explain in a better way because subjective different people can have the different perspectives, so values should be there. So RNFL with the traditional OCT cannot differentiate whether the disc edema is decreasing due to reduction in ICP or it is an axonal loss. So here come the GCL which indicates that axons are indeed dying off if it is showing the thinning. So OCT picture of a patient with unilateral disc edema which is showing the normal GCL IPL thickness. So here in such kind of patient you can explain a better prognosis. You can tell that the prognosis is good. So similarly here, you can see that the GCL is already thinned out. So you can explain the prognosis as per the GCL findings. So another study done by Mark J. Coopersmith, they have shown that there is a positive inward angulation of the peripapillary RPE and basement membrane relative to the peripheral peripapillary region. So there is a positive angulation inward toward the vitreous. And they have concluded that it is RPE basement membrane is commonly deflected inward in contrast to the eyes with NAION or optic neuritis where this finding was not there. So this angulation is presumed to be caused because of elevated pressure in a subarachnoid space, but it does not correlate with the amount of RNFL. This is just a finding. We cannot correlate this angulation with the RNFL thickness values. So now another publication where the OCT features and correlation of functional structural parameters have been seen in IIH patients. So Banerjee et al., they have studied this. And they have concluded that in setting of severe papilledema, RNFL can misguide the prognosis. So GCL-IPL can be a valuable tool for an objective evaluation of the integrity of optic nerve. And optic disc height may be used as an alternative or in combination with the GCL-IPL in these cases. So now papilledema versus drusense, optic disc head drusense. So in drusense, usually you see the thinning of RNFL and GCL. Whereas in papilledema, definitely it is the increased thickness. And the second important thing is a subretinal hyporeflective space between the RP and choriocapillaries, which suggest of optic disc drusense. And for Burritt, definitely the swept source and enhanced depth can improve the diagnostic detection. So another, in optic atrophy, definitely you see the thinning of the RNFL, that is gross thinning of the RNFL. Similarly, in the Leber's hereditary optic neuropathy, thinning of the RNFL and GCL layers and the prognosis, as depending upon that, you can explain. So one another recent publication by John Chen et al., they have seen OCT in pituitary tumor patients where they have observed a nasal hemiretinal ganglion cell layer thinning in the pituitary patient, which was corresponding to the visual field defects. So this is one another important thing to see if there is any pituitary tumor patient coming to you. Perimetry definitely we have to do, but then before perimetry, sometimes the OCT shows the defect before the perimetry defects. So this is important tool in such patients. So in the last, what are the important points to consider? Different machines have different protocols. So patients should be reviewed on a same machine using the same protocol. All the OCT measurements are compared to the normative data of Caucasian subjects, which must be considered. An actual placement of measurement area should be checked and amended manually if needed. So if you are examining the optic nerve area, so that should be properly centered there. So you should manually amend also if there is some decentration, because otherwise the values will come fallacious. So thank you so much for the kind attention. If any doubt and any question to us, I would be happy to answer.
No questions to Dr. Anita? Good. So now we come to the last talk, the OCT and glaucoma.
So, ma'am has beautifully elaborated the role of OCT in neuro-ophthalmology, and she highlighted the importance of RNFL and GCL. I will go little basic in this because those are the last point to consider. Before reaching at those points, we have to see certain things in the OCT print. I will go on to that. So first, the glaucoma, we all know it is a multifactorial progressive degenerative optic neuropathy, and it is second most common cause of blindness. And OCT is a non-invasive tool to in vivo cross-section the optic nerve and retina. Historically, first machine was HRT, which used to measure the optic disc. Then comes the polarimeter, which interpolated the thickness of RNFL. It was not actually measured the thickness. OCT is the first machine which actually measuring the structure, and there is no interpolation. So OCT can measure the nerve fiber layer. It can see the optic nerve head measurements, and it can see the macular thickness. What is the importance of these three in glaucoma? As you can see in this picture, the ganglion cells, their axons, they exit out from the optic disc. So we are measuring the optic disc parameter. Around the optic disc, we are measuring the RNFL, which is basically the axons of ganglion cell. And in the GCL, we are measuring this ganglion cell and inner plexiform layer. So this is essentially a single structure which we are measuring at different areas. So as ma'am highlighted, there are different machines, and different machines have different algorithms. Like for RNFL thickness, they are taking different diameter circles. So we cannot compare one machine with another machine. So you should always do OCT on a single machine. Similarly, for the optic nerve parameters, the reference is different for different machines. So scans obtained with different instrument will differ in data, and you cannot compare on two machines. OCT is objective in nature, whereas visual field is psychophysical. So we have, I will be talking about Cirrus HD because we are using this, and I have no financial interest. So I have divided the whole printout into 7 parts. So we usually directly come to the part number 6 and 7, but before that there are 5 parts which we should consider before going to the 6 and 7. The first one is patient information. In this, we have to see the registration number, because if you will do on with a new registration number every time, the machine will take it as it is a new case, and it will not compare with the previous data. Age and sex is important because it is for the normative data. The machine compares your reading with the normative data, so age and sex is important. Second is signal strength. A poor quality scan will lead to a lot of problems in the segmentation. So in this, in our machine, it is out of 10, and you should get at least 7. This is NFL thickness map. It is basically topographic representation of the thickness. In a normal patient, it should look like this, in hourglass pattern of red and yellow. And the values are given here, color coding is given according to the thickness, and this is normal. For thinning, it will look like this. So, and what happened here, if you look at this, there is a black area. It is black because there is a floater in the vitreous which prevented the acquisition of data. So in such case, you will ask patient to look briefly to one side and then again fixate, so that opacity is on the side and you can actually capture whole of the data. If you will proceed directly to the 6th part, it is red, and you will say it is thinning, but actually the problem is data is not captured here. Similarly, if patient blink during the scanning, you will get this black line. So for this, you will ask patient to keep blinking physiologically when you are adjusting the machine, and just before starting taking the scan, you will ask him to stop blinking. The next thing you have to, at number 4, you have to seek the RNFL deviation map. In the deviation map, there is red and yellow dots. They are showing red one is thinnest normative data ka thinnest 1%, and yellow is thinnest 1 to 5%. So this is showing comparison with the normative data. Another important thing which we have to see here is placement of the circle at the optic disc. So this centration is important. If it is more than 0.3, your data will go haywire and you should not proceed. You should do the scan again, and this centration should, like in this case, it is decentered. It is 0.33. So it is not acceptable. You have to center it in less than 0.3. So in this example, as you can see, there are deviations. It happened because of eye movement during the scanning. Usually we ask patient to look at a fixation which is green in color and the scanning lines are red in color. So when patient is looking at the green circle, suddenly when red lines start coming, he suddenly moves his eye toward the scanning laser, and it lead to this kind of artifact. So you will ask patient specifically to keep looking at the green line spot and stop looking at the scanning lines. So you have to correct. If it is there, you can see at the 6th part it is coming yellow. Again, this is not reliable. Similarly, if I have done this, there is the patient, I have done this and I have manually decentered this, and you can see it is totally normal in this case, but it become yellow in this case because of decentration. And it is the same patient 5 minutes apart. Similarly, when I corrected it, the values are corrected. The 5th one is RNFL and optic nerve at segmentation. So you can click on the computer and you can see the 360-degree that segmentation is correct or not. In optic nerve head, there are 2 lines. One is black, one is red. So black ends at basement, then RP opening, that is BMO opening. You should see that in poor scans, it may move from its normal place and lead to the erroneous values. And the red one is the least distance from this. And in certain conditions, in poor scans, it may not be at the right place. So you have to manually check this before proceeding ahead. And similarly for the RNFL, there is segmentation here. So you have to check whether the segmentation is proper or not. Now we have reached the value which we see at the number 1. So here we can see the green color is there, gray color is there. The green color is when your data is between 5 to 95% of normative data, it will become green. When it is thinnest 1 to 5, it is yellow. If it is less than 1%, it is red. If it is thicker than 95%, it is white. Then what is gray? Gray is it is outside normative data. Here the disk size is more than 2.5. If it is more than 2.5 or less than 1.3, the data will be in gray. Or if your patient age is less than 18, then also it will become gray in color. So in this we see the average RNFL symmetry. For the disc we see the rim area, average CD ratio and cuff volume. But you should know the color coding. And similarly RNFL, this is shown in the graphical manner. The continuous line is for the right eye, hashed line is for the left eye, upper one is for neuroretinal rim and lower one is for the RNFL. And RNFL is also shown in quadrant and clock hour. So what is the importance of showing in the clock hour and quadrant? The importance is initially the glaucoma loss is in sectoral. It is in a specific clock hour. So for example, in this case, you can see it is red here, yellow here and white here. White means it is thick, it is borderline, it is thin. But when you will see the quadrantic map, it is flattened. It has become green. So it will give you the assumption that it is normal, but you should always look at the clock hour and correlate it with your visual field and clinical photograph. The GCL importance in neuro-ophthalm was highlighted by ma'am. Now it has importance in glaucoma also. So because essentially the RNFL and optic nerve findings are related with ganglion cell, it is the extension of axons are extension of ganglion cell only. So we have to check these also. It is measured by a macular cube of 6 by 6, and it is measured in a saucer shape. Basically, it is not measured in the central area. It is done because central area, there is foveal curvature, and in the curvature it is very difficult to measure. The ganglion cell layer is not there. It is very difficult to measure. So it is measured in a donut shape. The inner diameter is 1 millimeter and outer is 4 millimeter. And the values of GCL IPL thickness is shown as average as well as minimum. And the earliest changes in glaucoma is seen in inferotemporal quadrant. So you should always look at that quadrant, correlate with your glaucoma findings. There is one more software, glaucoma progression analysis. In this, when you are repeatedly doing OCT for a same patient, two baseline OCT, good quality OCT are taken at baseline, and they are compared with the future OCTs, and in these different values are compared, and they will give you possible loss, likely loss. If it is one event, it is possible, it is coming again, then it become likely. But like in this example, in certain part, it shows that the patient is progressing, but on the next visit, it become normal. It happens because there is 4 micrometer standard deviation in the machine. If you are taking values again and again for the same patient, there is 4 micrometer deviation. So for 2 standard deviation, there should be at least 8 micrometer deviation to be significant. Though the thing which I was highlighting, PanoMap, has also come, in which they are comparing RNFL, optic nerve, GCL and macular thickness in the same printout. And there is combined report in which they are, with the software, you can compare it with the visual field also. What is red disease? This normative data is for the normal persons, not for the atypical eyes or high myopic eyes, because those eyes have thin macula and their optic nerve head findings will not match with the normal patient. So when you will do OCT on a myopic patient for glaucoma, you will get thinning, and they are actually, when you will do the field, they are absolute normal, they remain there, and the GCL also thin, but because they are coming red because they are overall thinned out compared to the normal population. So you should not treat myopic patient on the basis of RNF, on the basis of OCT only. So at conclusion, I would like to say you have to look at the entire readout. Don't directly jump at the RNFL values. Maintain a good quality reading by monitoring the scan signal quality, alignment, centration, and watch out for the opacity and segmentation error. Look for focal changes, not just overall change. 3 most common RNFL progression patterns are new RNFL defect, widening of existing defect. If there is deepening, the deepening can occur because of aging effect. Because with age per year for the RNFL around 0.3 micrometer, the progression loss will be there each year. Use trend based. Basically, you have to follow a patient on a same machine and see the trend of RNFL. Don't compare one event with the whole of the baseline findings. And again, highlighting the same point, important and mandatory is the same machine, same place, reproducible image quality to ensure meaningful evaluation and follow-up. And last, there's one thing, floor effect. When there is advanced loss, the finding will reach in 50s, 45 to 50, and it will not decrease further even with the progression. And at that stage, you will not use OCT for evaluation. You will use 10-2 or visual field for the in monitoring. The OCT is of no use in advanced disease. Thank you.
Thank you, Anil. As we have come to the last talk, if you have any questions, I think we'll be very happy to discuss with you.
So one point I want to highlight for the glaucoma is that a single OCT may not be predictive of glaucoma. You have to have serial. Number 2, how do you correlate the disc, the fields, and the OCT? So you must have a disc photograph next to it. So do not, without a disc photograph or disc, analyze the glaucoma. Take a red-free photo, that will give you a better clue. Number 3, the ganglion cell only gives you the central 10 to 15 degrees. So the Heidelberg OCT gives you a 24 point. So your fields may not match to the ganglion cell, but if you see the thickness of the whole retina and with the macular thickness map, it may match to the field in the beginning. So you may have no field effect in the central 10 degrees, but you may still have glaucoma. and a vice versa. You may have ganglion cell but may not have a field defect. So either can be exclusive, and you have to be careful. Follow-up in glaucoma, the follow-up is most important, and we tend not to take a disc photograph. The disc photograph, I think, is more important than the OCT or the field, because that gives you a lot of clues, and the RNFL defect should match the disc photograph. If it is a error, it doesn't match, take a OCT again, because in a OCT, sometimes because of cataract or the quality of the image is poor. Okay, thank you.
Myopia, how it helps?
Pardon?
OCT, how it helps in myopia?
In
Myopia.
so in myopia, the OCT doesn't it just for the glaucoma or for the other part.
Glaucoma.
So glaucoma is the problem, because until you have a swept source, you will have aberration. You have to put in the refractive error, and in myopia there is peripapillary atrophy. So OCT is not as accurate in glaucoma as in others. So the problem is that OCT only works in a clear media. OCT doesn't help in a prior PRP eye or operated vitrectomy eye or a myopia eye, because in all those cases you will have an error of, and especially in peripapillary atrophy when you're doing the RNFL, that's why you tend to see the ganglion cell layer if you think that the peripapillary atrophy is there. So that is the limitation of OCT. Floaters, media haze is a limitation. So we depend too much. Yes, you can say there is no glaucoma when you have a glaucoma suspect, but you can miss a glaucoma on the OCT in the beginning. So I think serial disc photograph, serial RNFL, defects on a red-free photo, the OCT, all add up to this thing. So I'll say if you do gonioscopy, use the central lens to see the disc. That will give you a lot of clue of things more than the fields and the other things.
So if you have no other questions, I think we are very thankful to the audience be with us, and so we conclude this session. Thank you very much.